Well, hello everyone. My name is Basil Torab, and I'm a physician from Syria, and I have Masters in Healthcare Administration. I'm here in Boston, Massachusetts. We have two special guests tonight for our conversation. We have Dr. Abdulrazzaq Al-Shaqaqi and Dr. Abdulghani Hamadi, and I'm going to ask each of them to introduce themselves. Dr. Abdulghani.
So my name is, again, Abdulghani Hamadi. I'm a pulmonary critical care specialist. I work in the Chicagoland area suburbs at a large trauma hospital called Advocate Christ Hospital.
My name is Abdulrazzaq Al-Shaqaqi, pulmonologist, intensivist, and I practice in Detroit metropolitan area in Michigan. My main practice is at William Beaumont Hospital, and I practice in the VA hospital as well.
Let me start with you, Dr. Hamadi. What type of cases have you been seeing since the start of COVID-19?
Well, we see all range of cases of COVID-19 infection. The Christ Hospital is a major hospital in the metropolitan Chicago area. We had up to about 220 patients with COVID infection admitted to the hospital at different levels. So the cases we see are all the way from mild pneumonia requiring maybe oxygen 2-3 liters, all the way to patients who are intubated on ventilatory support and then require ECMO because even ventilatory support is not adequate to treat their pneumonia and hypoxemia.
Dr. Shaqaqi, since the start of the pandemic, how has your work changed?
Well, Basil, I think that applies to most of the pulmonologists, intensivists. We shifted big amount of our work to the inpatient care as opposed to what we used to do before. We kind of do a lot of outpatient pulmonary care. Basically, we are offering now a little bit of tele-healthcare encounters to our patients who are still in dire need to get their chronic illnesses addressed during and in the midst of the crisis. But most of the work we're doing now, it's in the hospital. So, between every team, they have a different paradigm where, people will spend more time in the ICU. Some other people will spend more time in a step-down unit and in a general medicine floor. This way, we deal with the entire spectrum of the disease between mild, moderate, and severe cases, and all the way to the critical, cases in the ICU that needs ECMO support sometimes in addition to mechanical ventilation.
Wow, so there has been a lot of changes since the pandemic and a lot of challenges, I would imagine. Dr. Hamadi, what has been the most challenging part of this current situation during the pandemic? And, if I can also ask, what has been the most rewarding part?
Sure. What's been the most challenging is that this disease hit us and we don't even know how to treat it. We thought we knew, we started medications, and then we find out that this medication doesn't work. So we had to always adapt our treatment strategies based on what we know. And the fact is, the most challenging, we don't have studies that gives us solid data to know exactly what we treat these patients with. It's evolving every day. Every day we come up with new guidelines, and that sometimes can be confusing for the intensivist, for the nurses, and for the support staff. And that has been evolving, although I should say that in general, we have done a good job adapting our treatment to every new information that that comes up. And we have done that while we're treating patients in large numbers. However, I should also say that the most rewarding is when you have a patient who's been extremely sick on ventilatory support that actually discharges from the hospital. You see him out and going home, and we've had, of course, many of them, and it is very rewarding because it's someone was in a black hole, nobody knows what's going to happen, and suddenly they came out and back to life again. So that's been very rewarding.
I may add here to what Dr. Abdulghani said. Working in an environment with no guidelines is like shooting in the dark. You don't know if you're harming the patient by holding certain treatment or if you're providing any benefits by extending that treatment. But what makes it hard those people are critically ill, and most of them are dying away from their families. And I think this is, to me, that was the most challenging part, is what I can do to this family to assure them that we did everything possible within our capacity to save their loved one lives. And we didn't have any shortcoming from our end as we think. It is the hardest part when their patients are expiring with no loved one around them. Sometimes you cannot even do any video conversation or any video chat if the patient is intubated. A lot of nurses are helping using their cell phones to create a video encounters to show the family what their loved one are looking like in the ICU before they expire.
Yeah, I can only imagine how difficult this is for the families and the patients, and of course for you, the frontliners. So, Dr. Shaqaqi, on average, how long do the patients with COVID-19 who require to stay in the ICU, for how long do they stay there?
Well, this is 5 different practices in the area, but probably between China, Italy, and even in the US, I think we're hovering around probably 8 to 14 days in the ICU. We have many people who are in the ICU for 3 weeks, but I think if you want to put an average number, probably 2 weeks is fair number. I don't know if Dr. Hamadi has a different experience in his hospital too.
I agree. Once they get into the ICU, especially if they're intubated, then you can count on at least 2 to 3 weeks stay. Because even after they get extubated, they still require a lot of therapy and a lot of treatment. And some of them actually require even rehab because of their weakness and deconditioning. But in the ICU, as for your question, it's, I would say I agree, 2 to 3 weeks.
I see. So, not every patient who goes to the ICU would need intubation. But generally speaking, what's the percentage of the patients who require intubation and ventilation when they are in the ICU, Dr. Hamadi?
So I can tell you from our experience, 131 patients got admitted to the ICU. Of these, 97 or 98 got intubated. Mm-hmm. Now, of those, about 48 to 49 were extubated. So that's a pretty good, it depends on how you look at it, but it's a reasonable percentage. I know, for example, the best comparison is patients who have ARDS, who get intubated and get extubated. Recently, their mortality rate has improved. So this is about 50% extubated. And we had about 25 actually, unfortunately, didn't make it. Some of them while intubated, some of them after extubation. So you can see that the average is about maybe 50%. That's our experience, but I think Michigan's experience also is probably similar.
We're hovering around the same number, but I think we have a little higher mortality in between the different hospitals that I go to. Some of the mortality is not related to respiratory failure per se. Some hospitals, they have big shortage on different supportive care like dialysis or dialysis nurses. So our colleagues from nephrology, they've been very selective who to offer dialysis and who not. Some patients are expiring because of hypotassium and severe acidemia, and they're on a minimal ventilator support too.
So let's talk a little bit about patients who recovered from COVID-19. And I know it's too early probably to predict anything, and most likely we don't have the data to support any theory. But do you expect that patients who recover would have a long-lasting effect on their lungs from COVID-19? Dr. Shaqaqi, I wonder if you can answer that.
As you said, Bassel, it's probably too early to measure the extent of long-term damage from this severe and disease and critical illness, especially when it comes to ARDS or ARDS-like picture. There's still debate now about is that a typical ARDS that's happening from this viral pneumonia or something similar to it or looks like it. So I think we're now we're trying to understand the acute mechanism of the disease and the acute consequences. I won't be surprised if those patients will sustain long-term damage in their lungs after they, especially, this process, I think it's not similar to any previous viral infection where they get bad pneumonia and ARDS for a few days, and after that they either get better or they expire. Those patients are on a vent for 2 to 3 weeks. This is the average. And by the time they're out, they're still requiring supplemental oxygen. Some of them are going home with oxygen. But whether, they will sustain fibrotic process that will maintain long-term oxygen support in the future or not, it's hard to predict now. But I think it will be some long-term consequences, not only on the lungs. I'm thinking a lot of patients will require dialysis for a long period of time after they leave the ICU units. And some of them, of course, they will go through anxiety, depression, and PTSD as well.
I see, thank you. Dr. Hamady, I'm gonna go back to the operations of the ICU. From your perspective, what has been the greatest needs in the ICU for now? Is it staffing? Is it equipment? Is it ventilators? Can you talk a little bit about that?
It's all, but I can tell you our experience, we're actually pretty okay on ventilators. Staffing has been a problem, especially that some of our staff has become sick themselves and they had to be quarantined for, as you know, 14 days. So we have struggled to, in terms of staff, whether it's intensivists or nurses or nurse practitioners. So in our ICUs, we have not only intensivists, we actually trained non-intensivists to take care of these patients, of course, with supervision from us. So we have different specialties. We have nephrologists, cardiologists who stepped up and started treating these patients. The other issue, obviously, that everybody is talking about is PPE. And as we know, we got caught with a very limited supply of PPE. The need is great and there's not enough supply. So we had to do some innovative measures in order to preserve the PPEs. So you can use the same mask, you can clean it, you can do the face shield, all these measures simply to which we never had to do before. Everything was disposable before. Now we preserve it and clean it because there's not enough. So really it's a staffing mainly and the PPE. From our experience.
I see. So Dr. Hamady, you mentioned that you had to kind of like invent some innovative measures to preserve some of your PPE, some of the PPEs, and to kind of like to perfect to the best that you could, the operations and the functions in the ICU. Can you tell us a little bit more about other roles of innovation in COVID-19, about some of the technology that you have heard or used on patients?
Sure. So from a simple box that protects the physician from intubating patients. We never used that box before. Now we have boxes that the patient protect the physician because, as you know, intubation is probably the riskiest procedure for the healthcare provider. So they actually invented some boxes that reduces the aerosolization. Also, some people are using sometimes the BiPAP machine instead of a ventilator. And then we also have something called a helmet. So the helmet is put on a patient's head, and then it can connect to the BiPAP, which is the non-invasive ventilation. The problem with non-invasive ventilation, which can save the patient from being on the ventilator, it's very aerosolizing procedure, and people were hesitant to use it, as well as the high flow nasal cannula. So in order to reduce that exposure, there's a helmet that we started using where the patient can be on a non-invasive ventilation and even use high PEEP, yet the aerosolizing procedures are much less. In addition to a lot of medications that we are finding out, we had to come up with a lot of protocols that patients fit in, because not everybody is expert. In fact, most of us are not expert on this disease. We're just learning. So when you have a hospitalist who need to treat that patient, you need to give them a protocol that they can follow. So it makes it easier for them to treat those patients. So we have to come up with a lot of protocols, and it keeps changing every day according to the data that what we have.
Dr. Hamada, you have the helmet. That means you're sitting in the ivory tower.
Well, we ordered a few of them, actually. We ordered 1,000. So we're waiting. We have a few and we ordered 1,000.
I was pushing for these helmets here big time. And I totally agree with you. Basil, I can follow with you, after Dr. Hamada said, one of the new innovation that I really like the most, it's not from doctors, it just tells you how the community is standing together. Michigan, we're the auto city here, and Ford and GM, they've been making gowns out of the airbags.
Wow.
Material. And they donate that to the hospitals. They're washable, they're durable, and they're great.
Yeah, very good. Actually, one more thing that is funny, when you walk in the hospital now, you look at people, whether it's nurses or workers or physicians, and you see all kinds of masks that are funny. People make their own masks. And now people are looking, actually it's pretty funny and cute when you see all these masks, and people are really feeling. I can tell you that there are doctors and the nurses in the hospital that work there have never felt the warmth of people treating each other with utmost respect, because we all know that those people that are working there, they're risking their own lives. And the tension that sometimes between, why did you call me? Why? I don't see that at all. It's really a very collegial and respectful relationship that I see now.
You mentioned so many things, the role of the community during this pandemic and the partnership between the physicians and the nurses and the other medical staff. So, Dr. Shaqaqi, what would you say to the community? Is really the quarantine working?
Honestly, Basil, we feel it. Actually, in the last few days, we started feeling the impact of this quarantine. I'll say probably starting in the middle of March until now, the crunch we have in the system, it was beyond what someone can handle. As Dr. Hamada said, we're short on equipments, we're short on staff, a lot of staff getting sick. And in addition to that, there is some disorganization in any hospital now, because it's a new entity, new disease we're dealing with no guidelines. So we come up with a plan, we implement it for a day or two, then, we revamp things and come up with a different plan that sometimes takes a lot of changes. The fact, we were able to slow the influx to the hospital, that helped big time. And I can tell the steady level of operation we have in the hospital in the last week or two is way better than what it was the few weeks before. So stay-home orders worked very well in Michigan. The crunch on the system is way less. Doctors are more relaxed, nurses are more relaxed, the equipment is now more available, and people now understand more about the disease as we go. I don't know how it feels in Illinois now.
I agree, it's the same. We have seen a stabilization of numbers. We peaked, I think, at 220 in the hospital. Now we're around 190, and it's been like this for the last 3 or 4 days. So I know staying at home is not an easy, it affects people's livelihood, and obviously affects the economy. However, and it may not shorten the disease, shorten the period where the disease will be around, but it makes it easier for the healthcare workers to treat these patients instead of being swamped all at once. But it may prolong it, we don't know.
So speaking about the time, Dr. Hamada, for how long do you think the whole pandemic would go? I know nobody has a crystal ball to tell, but what's your expectations?
I'd be a rich man if I knew the answer. But I'll tell you, no, obviously we don't know, but it is expected to slow down, and then we may hit another wave. But I think this is gonna be with us for the next at least 6 months. I don't see it going away in a month or two. It may slow down to the point where social distancing will be easier, but this is gonna be with us at least for the next probably 6 months, my guess would be. And it will only go away or become only sporadic when we develop the vaccine, when if everybody gets immune. But that takes a long time.
I see. Dr. Shaqaqi, I'm going to jump into a different subject now. I'm going to ask you about the patients who are not in the ICU, who do not have COVID-19, who are not in the hospital, but those are the patients who have pre-existing pulmonary disease. And I'm sure a lot of them are worried right now because, their pulmonary disease puts them at a higher risk for COVID-19. What would you advise them? Do they have to follow the same general precautions as the general population, or do they have any specific precautions?
The non-COVID-19 patients, I feel like they're not in the scope now of any discussion, and I feel bad for them. Definitely pulmonary patient or patient with a chronic pulmonary condition, they have really higher risk of acquiring the infection and having the severe form of the infection. So if they get admitted to the hospital, they likely will end up in the ICU. And if they get intubated, their chances of leaving the hospital is very slim. So what I tell them, the least you can do is you take these stay-at-home orders more seriously than your colleagues or your peers. To help them over the phone as we can, I try to not bring them to the clinic unless they really need to see a doctor. And I hate to send them to the ER because we know how these ER now, they're mostly ER COVID now. So whatever we can manage over the phone, and they feel very grateful to that because, they themselves, they don't want to leave the house. I feel that in my patient, they're scared. And they understand lung problems, chronic lung problems mean a higher risk for death if you contract any pneumonia. So the least they do is to stay at home, get some help from their families and from their doctors over the phone as possible. Try to avoid ER visit as possible or urgent care visit as possible, unless their doctor advised so.
Hamada, would you add anything to that?
No, actually, I think that's a very good advice, and that's what we're doing as well.
Thank you. Dr. Hamada, I also heard that you have been leading the SAMS effort or free helpline in Chicago. Can you tell us a little bit about that?
Yeah, well, actually, it's the mayor in our area put out a request asking for volunteers to help those patients that are staying home. We tell people to stay home, but what about those chronically ill patients who have issues and they need to see the doctor, for example? And is there anyone who can help them answer the questions or even see them? So we put together a team of medical assistants, and we have a hotline. So those patients will call that hotline, and if the medical assistant can manage, they will answer. Otherwise, we have a group of physicians with different specialties that actually volunteered to help those patients if need to. So if they need to, we call them, or we do telehealth. And we haven't had to go actually in a home and see any of the patients yet, but we're willing to do that if need to. But we've been talking to patients, even arranging some treatment or transfusion in one case, because not everybody has insurance. And then now, as you know, a lot of patients are out of work and they need help. So we didn't limit it to our only our area. So we actually expanded it to surrounding suburbs, and we're getting a few calls.
Well, thank you. This is a great, it's heartwarming. And before we conclude, I just want to ask each of you if you could provide us with a happy story of a patient that you treated during this pandemic. Dr. Shaqaqi, I wonder if you can share a story with us.
Well, I think the happiest story is when you see the patient is walking the door of the hospital home after they had a tough course in the ICU. And in fact, that patient, before she left, she's a lady in her like 50s. She hugged me. She said, you're my family now because, I don't have any family here next to me. And they're just waiting in the car. They're not allowed to be in the hospital. And she was escorted, on a wheelchair. So the fact you feel like you're a treating physician, you're the family, you're everything, yourself and the nurse as well, of course. And I feel the bond and the relation between the nurses and those patients and their families is tremendous.
Feeling I can imagine, and I could only think, if I'm a patient and you and the nurse are the only thing that stands between me and death, I would truly be very appreciative to you. So thank you for sharing that story with us, Dr. Shakaki. Dr. Hamadi, do you have any story to share with us?
Yeah, actually, I saw a patient today. He was in the ICU, intubated on 100% oxygen, high PEEP, and then he had an ECMO. And then just today, he was extubated actually 2 days ago, and today he was decannulated from the ECMO. So right now, he's still in the ICU, but he's breathing on his own, he's talking, he's eating, he's very happy, and the ECMO is gone, the ventilator is gone. He's gonna do well. I mean, all the nurses were really, really very happy with that ending, because once you go on ECMO, it's very hard to get off of it.
How old is he, Dr. Hamadi?
He is in his 50s.
That's great. Imagine losing someone who's 50 years old just for a viral infection.
So Dr. Hamadi and Dr. Shakaki, I cannot thank you enough. When I look at the streets, it's very quiet outside, but this is false perception, because I know it's completely a different story in your day-to-day work in the ICUs. And thank you so much for taking the time to be with us here and for sharing this information. And I thank you again for all what you do for treating our patients. You are the true frontliners, and there is no word to describe how much the whole community is grateful to you all. Thank you.
Oh, very welcome.
Thank you, Basil, for having us.
Thank you for having us.
You're welcome.